When you are discussing the treatment of hypertension, we must understand certain points. The goal of the treatment of hypertension is to prevent long-term sequelae, that is target organ damage. So the goal is to prevent target organ damage. You see, the end organ damages can be, it can be cerebrovascular, it can be CNS, that is, it can be CVS, it can be renal, it can be arterial. Several, we discussed this before, like in cardiovascular, it is MI, pulmonary edema. In neuro cerebrovascular, it can be stroke, TIA, ischemic, then seizures. In eye, it can be retinopathy. In kidney, it can be azotemia, high levels of creatines, and kidney injury can occur. Like arterial, it can cause dissections, coarctations, all those things can occur. Okay. So to prevent these organ damages, we are treating the hypertension. So we are also, it is also important in controlling other modifiable cardiovascular risk factors. In isolated systolic hypertension, the therapeutic goal should be to lower systolic blood pressure to less than 140. Systolic blood pressure more than 140 is associated with increased cerebrovascular and cardiac event. So there's a case of isolated, in isolated systolic hypertension, we must um, target is always less than 140 millimeter of Hg. If it is high, it can cause uh, cerebrovascular as well as cardiac events. Next, in patients with CKD, kidney disease, in patient with kidney disease, that is chronic kidney disease, you see, or it can be diabetes mellitus. The BP should be reduced to a goal of less than 140/90. The target is should be less than 140/90 millimeter of Hg. This is the target that we set for a patient who is having a kidney disease or a diabetes mellitus. Next, if a patient is having a, if the patient's age is more than or equal to 60 years and no CKD, no chronic kidney disease, or no diabetes mellitus. In such case, the BP should be reduced to a goal of less than 150/90. So in this case, the target BP is less than 150/90. Discretion is warranted in prescribing medications to lower BP that may affect cardiovascular risk adversely in other way. Example, glucose control, lipid metabolism, uric acid levels. What does it mean? So if a patient is normal, just is age-related problem, age-related, no kidney disease or diabetes, we are unnecessarily, if we are adding medications, you should understand the risk-benefit or the ratio, risk-benefit ratio, whether it affect the glucose control, whether it affect the lipid metabolism or the uric acid level. You know, especially thiazide diuretics, there can be uric acid high. Some uh, thiazide diuretics also cause a lipid hyperlipidemia and hypokalemia and hyperglycemia also, certain thiazides. So before you starting the drug, you should think of it whether we should start or not, counting or taking into the factor the risk adversely. Lifestyle modification should be encouraged in all hypertensive patients, regardless of whether they require medication. These changes may have beneficial effects on other cardiovascular risk factors. Some of these lifestyle modifications include cessation of smoking, reduction of body weight. If the patient is overweight, judicious consumption of alcohol, adequate nutritional intake of minerals, vitamins, reduction in sodium intake, and increased physical activity. You see, the lifestyle modifications and its effect. See, firstly, you should understand one thing, that is weight reduction. weight reduction, that is for every 10 kg loss, for every 10 kg loss of weight, there is a reduction in BP of 5 to 20 millimeter of Hg. That is systolic blood pressure decrease. Okay, for every 10 kg reduction, there is 5 to 20 millimeter of Hg reduction in the blood pressure. Next, DASH diet. DASH diet means dietary approach to stop hypertension. If you're using DASH diet, it can reduce BP, that is 18 to 40 millimeter of Hg. That is, these are studies conducted by the American Heart Associations. Next, if you are taking very less dietary sodium, salt intake, less, that is less than 2 gram per day. The salt intake is less than 2 gram per day. It is 2 to 8 millimeter of Hg reduction. Similarly, if the physical activity, you see physical activity, that is 150 minutes of physical activity per week, 150 minutes of physical activity per week, it can reduce the BP around 4 to 9 millimeter of Hg. Okay, next, the moderate, that is moderation of alcohol consumption. Moderation of alcohol consumption, that is less than 2 drinks per day. If it is less than 2 drinks per day, the reduction can be 2 to 4 millimeter of Hg. Okay, so barring an overt need for immediate pharmacological therapy, most patients should be given the opportunity to achieve a reduction in BP over an interval of 3 to 6 months by applying non-pharmacological modifications and pharmacological therapies if needed. So there should be at least 3 to 6 months is the period that we give for a patient without pharmacology or with pharmacology to control the BP. Next comes the medications that we start. Coming to the medication, you see there are initial drug therapy, additional therapy, adjustment of therapeutic regime. So first is initial therapy. In initial drug therapy, we see that initial drug choice may be affected by coexisting factors such as age, race, angina, heart failure, renal insufficiency, LVH, obesity, hyperlipidemia, gout, bronchospasm. Cost and drug interaction should also be considered. BP response is usually consistent within a given class of agents. Therefore, if a drug fails to control BP, another agent from same class is unlikely to affect. So if I give a one class of drug, for example, it can be calcium channel blocker. If the patient is not responding to the calcium channel blocker, there is no point in giving another calcium channel blocker because it is very unlikely to be effective. At times, however, a change within a drug class may be useful in reducing adverse effect. The lowest possible effective dosage should be used to control BP, adjust every 1 to 2 months as needed. So you should start with lowest possible dose. Okay, you start with the lowest possible dose. Discussing the next point, diuretics, calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers. It should be considered as the first line medication. Considered as the first line medication. So, what's multiple large randomized control trials have shown comparable effect on decreasing overall cardiovascular and cerebrovascular mortality for all four classes of drug. So in general, black population, including those with diabetes, a diuretic or a calcium channel blocker can be considered first line therapy. See, a black population, those with diabetes mellitus can think about diuretics or calcium channel blockers as the first line medications. Data from the ALL-HAT trial, that is an important trial done in considering the data from the ALL-HAT trial, that is ALHAT. What does it mean? It means antihypertensive and lipid lowering treatment to prevent heart attack trial. So the trial has shown decreased cerebrovascular as well as cardiovascular mortality and morbidity with the use of thiazide diuretics or calcium channel blockers over an AC inhibitors. So this trial has shown that this trial has shown that using thiazide diuretics or calcium channel blockers has outranged or it has become good over ACE inhibitors in reducing mortality and reducing morbidity, especially due to cardiovascular as well as cerebrovascular events. Okay, so this is all hack trial, that is thiazide diuretics, calcium channel blockers. In patient with chronic kidney disease, you see, if a patient who is coming with a chronic kidney disease, a CKD patient, CKD, chronic kidney disease, initial or combination therapy with ACE inhibitors or ARB should be considered. So here in chronic kidney disease, you should consider a combination therapy with ACE inhibitors as well as ARB. It should be considered in kidney disease. That is about the initial therapy. Next comes the additional therapy. Next is the additional therapy. Coming to additional therapy, when a second drug is needed, it should generally be chosen from among the other first line agent. So the first line agent, as we told, it is AC inhibitors, ARBs, calcium channel blockers, and diuretics. So if I use AC inhibitors and ARBs, the patient is not tolerating that. You should add another drug from the same first line medication. It can be calcium channel blockers or it can be diuretics. Understand? Next comes the adjustment. Of this regime. Before considering a modification of therapy because of inadequate response to the current regime, other possible contributing factors should be investigated. Poor patient compliance, use of antagonistic drugs like sympathomimetics, venlafaxine, TCA, MAVO inhibitor, chlorpromazine, steroids, NSAIDs, cyclosporin, caffeine, thyroid hormone, cocaine, erythropoietin. Inappropriately high sodium intake or increased alcohol consumption should be considered and may be the cause of inadequate BP response. So considering adjustment, we should keep in mind some important BP occurring or BP promoting agents like drugs, especially you think about the sympathomimetic drugs amphetamines. Then you think about venlafaxine, that is SNRI. Then you think about tricyclic antidepressant, TCA. You think about steroids. You think about MAVO inhibitors. You think about chlorpromazine, antipsychotic. Think about cocaine, especially cocaine withdrawal. Hormones like thyroid hormone. There are certain other factors also. Most commonly we use NSAIDs. It blocks prostaglandin, that's why it causes BP. So these are some main important drugs. So check about that one, whether they are using these or that. Secondary cause of hypertension should also be considered. We also previously discussed about that. Secondary causes. When analyzing the test, suspecting means less than 30 years, more than 60 years. If it is BP is uncontrolled, you should suspect a secondary cause. Cushingoid features. Then hypokalemia or metabolic alkalosis, not explained by diuretics. Okay. And young hypertension. In all those things, we should suspect secondary cause. Secondary cause, when you're discussing secondary cause, it can be many, like primary aldosteronism, Cushing syndrome. It can be coarctation of aorta. It can be pheochromocytoma. Many um, theories have been there. So next is the drugs that we are dealing about. See, this is a commonly used antihypertensive agents by functional class. First is beta adrenergic agonist, then calcium channel agonist, then come AC inhibitors, then comes the ARB, receptor blocker, direct drain inhibitor, diuretics, alpha adrenergic agonist, centrally acting, direct acting vasodilators, certain messenger drugs. So before going to that, we must understand one thing. You first you can study about diuretics. We told that in a patient who's having a kidney problem, we start with AC or additional therapy with AC and ARB. Who's having a diabetes mellitus, we start with the calcium blockers or diuretics. That's important. So diuretics means what they do. There are certain functions for diuresis. Aquaresis is water loss. Diuresis is water as well as electrolyte loss. So they are effective in therapy of hypertension and have been shown to reduce the incidence of stroke and cerebrovascular events. Several classes of diuretics are available, generally categorized by their site of action in kidney. First, you see uh, thiazide diuretics. These are commonly used diuretics. Thiazide diuretics. Thiazide, where they act. Thiazide diuretics. Thiazide diuretics, it acts on the sodium chloride pump. Uh, this is a lumen here. Urine is passing over here. The distal collecting tube, that is DCT. There is a channel called sodium chloride co-transporter. So this drug called thiazide diuretics, it blocks this channel, which leading to release of sodium chloride into the urine. So there are drugs like hydrochlorothiazide, then chlorthalidone. These are drugs. They block the sodium reabsorption predominantly in the DCT. by inhibiting the thiazide-sensitive sodium chloride cotransporter. These diuretics can produce weakness, muscle cramp, impotence. Metabolic side effects include there are some metabolic side effects for these diuretic. Okay, side effects include hypokalemia. The side effects: hypokalemia. This is low potassium because sodium electrolytes are lost. In hypomagnesemia, the magnesium levels will decrease in the blood. Then the calcium level will increase calcium, that is calcium hypercalcemia. And the glucose level also high, that is hyperglycemia. Then uric acid increases, hyperuricemia. Then the sodium is lost in the urine. Here we can see the sodium is lost in the urine. So hyponatremia, lost sodium. Metabolic side effects may be limited when thiazides are used in low dose. Thiazide-induced pancreatitis has also been required. So when used in low dose thiazide diuretic means we use hydrochlorothiazide 12.5 milligram. There is a low dose hydrochlorothiazide. It can be up to 12.5 to 25 milligram. Low dose. This is about the thiazide diuretics. Then comes the loop diuretic. Loop diuretic, it acts on the loop of Henle. Okay, so how they act in the lumen, we know is the lumen of a loop of Henle, that is ascending loop of Henle. There is a channel called this is a channel called 1 sodium 1 potassium 2 chloride symporter. So the loop diuretic will block this channel, resulting this is like 1 sodium 1 potassium 2 chloride, so absorption into the blood. So blocking this will excrete all these content in the urine, all sodium potassium chloride excreted in the urine. So for example, for these are of furosemide, that is Lasix. Next is the drug called bumetanide. Next is the drug called ethacrenic acid. These are the drugs. Okay, you see also one drug called Dietor, that is torsemide. That is Dietor. It blocks the 1 sodium potassium channel in the thick ascending limb. The most effective agents in patient with renal insufficiency. So the patient who are facing renal insufficiency means their GFR is less than 35 ml per minute. In this such patient, this loop diuretics are best. Usually dose related and more common with parenteral therapy. What? Adverse effect. You see, the adverse effect include the side effects of the furosemide is metabolic alkalosis, the metabolic side effects. Next, it causes hypomagnesemia. Next, it causes hypocalcemia. It can cause hypokalemia. It can also cause ototoxicity. That is dose related. Because metabolic alkalosis means there is retention of bicarbonate. Okay, loss of H plus. Next comes the potassium sparing diuretics, that is a spironolactone. See, in the previous side, the main side effect is using fruzimides is the hypokalemia. That is why potassium H plus K plus channel very important. The potassium is losing. So hypokalemic metabolic alkalosis. So now this is spironolactone and eplerenone. What are these? These are potassium sparing diuretics. These are potassium sparing diuretic agents. Most of the furosemide diuretics loses potassium, but this spares potassium. Aldosterone antagonist also spares potassium. Okay, what are aldosterone antagonists? These are spironolactone, eplerenone. So they act by competitively inhibiting the action of aldosterone on kidney. Tramterine and amiloride are a potential inhibitor of sodium and secretion of potassium ion. Potassium sparing diuretics are weak agents when used alone, thus they are often combined with thiazide for added potency. So how is the action of amiloride? The spironolactone mechanism of action is they are competitive antagonist. It blocks aldosterone, competitive antagonist of aldosterone, as well as it blocks sodium potassium channel, hereby secreting potassium and retaining sodium. Secreting it resulting in secreting sodium and retaining potassium. Uh, so potassium loss is reduced. So the main problem, the aldosterone antagonist may have an additional benefit in myocardial function in heart failure. So this eplerenone, this drug useful in heart failure patients. That's why we use eplerenone drugs, hydralazine, nitroglycerin. These are very good in heart failure patients. It can, like this spironolactone, that is this drug can cause increased potassium in the blood, hyperkalemia, but no lipid problems, lipid alteration occurs, unlike thiazide diuretics. Okay, keep in mind. There's another drug called amiloride, which is also a potassium sparing, which block the epithelial sodium channel and the distal convoluted tubule and collecting duct. Similar mechanism of action, it blocks the epithelial sodium channel, so it decreases the absorption of sodium. So sodium lost in urine and potassium is absorbed. So potassium is uh, decreased lost in urine. So potassium prevention, loss prevention, like that.